There are now more effective cholesterol-lowering medications than ever before. When lifestyle changes alone aren't enough, or when your risk is high enough that medication is needed right away, your doctor has a whole toolkit. Let's go through each one. Let's start with statins, which are the foundation. They are the first line medication for most people with high cholesterol. They work by blocking an enzyme in your liver called HMG coenzyme A reductase. That's the key enzyme your liver uses to manufacture cholesterol. With less cholesterol being made inside the liver responds by increasing the number of LDL receptors on its surface, which then pulls LDL out of your bloodstream like little vacuum cleaners. Statins lower your LDL by 30 to 55% depending on the type and the dose. They reduce the risk of heart attack and stroke by 25 to 35%. Common examples include atorvastatin or Lipitor, rosuvastatin or Crestor, and simvastatin. They're taken as a daily pill. Statins also have anti-inflammatory effects in the arteries that go beyond LDL lowering, which is one reason that they reduce heart risk even more than just because of the LDL drop alone. Ezetimibe is an add-on. It works differently from statins. Instead of affecting the production in the liver, it blocks a protein in your intestine called NPC1L1 that absorbs cholesterol from your food and bile. Less absorption means less cholesterol gets delivered to the liver, and the liver responds by pulling more LDL from your blood. Ezetimibe lowers LDL by about 20% on top of whatever a statin achieves. It comes as a daily pill and is often combined with a statin in a single tablet. It is extremely well tolerated. It's one of the safest pills available. PCSK9 inhibitors are the powerful newcomers. PCSK9 is a protein in your liver that normally destroys LDL receptors, which reduces how efficiently your liver clears LDL. PCSK9 inhibitors are antibodies that neutralize PCSK9, allowing your LDL receptors to survive longer and to keep working, pulling massive amounts of LDL out of the circulation. There are two types of PCSK9 inhibitors, the injectable antibodies, alirocumab and evolocumab, called Repatha. These are given as self-administered shots under the skin once every 2 to 4 weeks, similar to an insulin pen. Inclisiran is an RNA-based injection given twice a year in the doctor's office. Instead of blocking PCSK9 directly, it stops the liver from making PCSK9 in the first place using a technology called siRNA. PCSK9 inhibitors lower LDL by 50 to 60% on top of maximally tolerated statins. They also reduce Lp(a), which is that independent genetic risk factor, by 15 to 30%, which is a meaningful bonus. They are recommended for very high-risk patients, those with familial hypercholesterolemia, statin-intolerant patients, or those who haven't reached their LDL goal despite statin plus ezetimibe. Bempedoic acid. That's for statin-intolerant patients. So bempedoic acid targets a different enzyme in the cholesterol production chain. It's an enzyme called ATP citrate lyase. Crucially, this enzyme is not active in muscle cells, only in the liver. This means bempedoic acid does not cause the muscle aches that some people experience with statins, making it an excellent option for statin-intolerant patients. It lowers LDL by about 18 to 22%. It's available as a daily pill, including in a combination with ezetimibe. Bile acid sequestrants, which is the oldest option. Bile acid sequestrants such as colazevilam work in the gut. Acids made from cholesterol in your liver normally get recycled back into the bloodstream. These medications bind bile acids in the intestine and carry them out to the stool. So your liver then has to make new bile acids, using up cholesterol to do so, which lowers your LDL by about 15 to 18%. They're not a first choice today due to gastrointestinal side effects, but they uniquely improve blood sugar in diabetics, which is a bonus for some patients. Now, there are newer and specialized agents. Evolocumab. It's for patients with the rarest, most severe inherited high cholesterol, homozygous familial hypercholesterolemia. It blocks a protein called ANGPTL3, which lowers LDL even when liver LDL receptors don't function at all, given by IV infusion monthly. Lomidopide is for the same very rare patients. It blocks a protein that assembles VLDL particles in the liver. Very powerful, but limited to specialized lipid clinics. High-dose prescription omega-3 fatty acids, specifically isopentanoic acid or Repatha, at 4 grams a day dramatically lowers triglycerides and has been shown to reduce heart events in patients with high triglycerides independent of LDL. So let's talk about a stepwise approach. The 2026 guidelines emphasize a clear stepwise approach. You start with statins and lifestyle changes. Then you add ezetimibe if your LDL goal is not met, and add a PCSK9 inhibitor for very high-risk patients who still haven't reached goal. This is now evidence-based practice, and it applies to both primary prevention and secondary prevention after a cardiovascular event.